appetite present. No history of cough with hemoptysis or breathlessness. Past history. Patient was a known case of type 2 diabetes mellitus for the past 2 years, who's on oral hypoglycemic agents. Also, he is known case of systemic hypertension for the past 2 years. He is on antihypertensive drugs. He is not a known case of tuberculosis, bronchial asthma, seizure disorders. No history of any significant previous surgeries or hospitalization for the same complaints. Personal history. He consumes mixed diet, bowel and bladder habits normal. He is not an alcoholic or smoker. Family history. No significant history suggestive in the family. General examination. A patient was moderately built and poorly nourished. ECOG performance status 2. Patient on pallor is icteric, afebrile, bilateral pitting pedal edema present. No cyanosis, no clubbing, no signs of liver cell failure. After getting vital sign, BP 130/90 mmHg, which is measured in right arm in sitting posture. Pulse rate 90 per minute, which is normal volume, regular rhythm, no abnormal characters. Temperature normal. After getting proper consent from the patient, the adequate exposure, abdomen examined. On inspection, abdomen fullness noted in the epigastric and right hypochondrium. Umbilicus in midline position, inverted. All quadrants moves equally with respiration. Skin over the abdomen, no scar, no sinus, no dilated veins, no scratch marks. No visible gastric peristalsis or intestinal peristalsis seen. On head raising test, the fullness noted in the abdomen decrease in size. Bilateral flanks free. Bilateral hernial orifices, no visible cough impulse. External genitalia normal. Bilateral renal angle free. Left supraclavicular fossa, no fullness note. On palpation, there's no local rise in temperature. An ill-defined mass of size 8 x 7 cm present, occupying the epigastric region, extending laterally up to 3 cm from right midclavicular line, left side up to left midclavicular line. The superior border is could not be identified. Below, it is extending up to 7 cm from the zipisternum. The mass, which is irregular in shape, nodular surface, hard in consistency. Border of the liver is rounded. Swelling moves with respiration. Hands could not be insinuated between the subcostal margin and mass, which seems to be arising from the left lobe of the liver. And the right lobe of the liver is also enlarged up to 6 cm from the right subcostal margin. The plane of the swelling is intra-abdominal. No other mass palpable in the abdomen. Bilateral flanks free. Bilateral hernial orifices, no cough impulse. External genitalia normal. Bilateral renal angle, no tenderness. Left supraclavicular fossa, no lymph nodes palpable. Percussion, dull note over the swelling present, which is continuous with the liver dullness. Liver span is 16 cm, no free fluid abdomen. Auscultation, bowel sounds here. Digital rectal examination, is normal sphincter tone, no mass lesion or mucosa normal, no Bloomer shelf, normal fecal staining present. Other system examination, CVS, S1, S2 here, no abnormal heart sounds. RS, bilateral air entry present. CNS, no focal neurological deficits. Summary, a 58 years old male, known diabetic and hypertensive for the past 2 years with the complaints of yellowish discoloration of the eyes for the past 2 months, which is insidious onset and non-progressive, not associated with pain, fever, with the significant loss of weight and appetite. This examination, this patient was poorly nourished, moderately built, icteric, anemic, with the pitting pedal edema on both legs, with the ill-defined liver mass of size 8 x 7 cm present in the epigastric region, which is hard in consistency, nodular surface, rounded liver border, which also moves with respiration. With the other systems are normal. Diagnosis, probable diagnosis, a case of liver mass probably due to primary hepatocellular carcinoma. Hello, sir.
Yeah, that was a good presentation. Over to the surgeons here. Dr.
Okay,
Kaarthesan and Dr.
Jeyamohan, can I ask you a few
Yes, sir.
questions? Okay, so I think we will start with the management plan. So you have presented the case presentation very well. So why do you say that
Yes,
it's first of all a liver mass? What made you think that it's a liver mass clinically?
So clinically, the mass was occupying in the epigastric and right hypochondric regions, sir. And it's an ill-defined mass which fingers cannot be insinuated between the subcostal margins and the mass. And percussion, the dull node present over the mass, which also extending towards the extending along with the liver dullness, and also it moves with the respirations.
Good. Okay, so your liver mass is your first differential diagnosis. So what are the other possible differential diagnoses you want to put here? What are the differential diagnoses
in
for
the
any
epigastric
other
region? Yeah. Epigastric region, sir. So probably a stomach mass with and a pancreatic mass, head of pancreatic mass.
Okay, so these are the two common possibilities which you say. Okay, so why do you tell it as a primary hepatocellular carcinoma? Why not it can be a cyst in the liver or a metastasis in the liver or anything else? Why did you tell that probably a primary HCC?
He's a 60 years old male, sir. Old age person with a history of jaundice. It's non-progressive jaundice, sir, and also painless jaundice. And no other history suggestive from primary, sir. Any colorectal malignancy, stomach, or other malignancy, no history suggestive, and no history of fever. So I'm ruling out other primaries and infectious causes of
okay,
liver.
so you are telling that it is a means painless progressive jaundice, right? So
yes, sir.
If this patient didn't have
painless non-progressive, sir.
Okay, so painless non-progressive jaundice. Okay, so in the case of painless jaundice, if you didn't feel this mass in your abdomen, what would be your thought process? If you don't feel this mass,
would be in
the same
periampullary
case. So what do you think? Okay, good. Okay, and how common it is to have a HCC in the liver with jaundice? Is it common or not?
Uncommon.
Yeah, it is not common because it is not common. Okay, fine. And if you tell us specific to HCC, what other important history, at least from postgraduate point of view, which you missed? What are the common causes of HCC?
Sir, our country most common cause is infectious cause, sir. Hepatitis B.
Yeah.
And cirrhosis of liver, alcohol.
Yeah, so you should ask about the causes which can cause hepatitis B, something like blood transfusions. Yeah, receiving. You should tell a little more, and you have told about alcohol, but still some little more in detail about alcoholism. Okay. Okay.
Before going to the next step, let me add few more points. Okay, yes. If I may, you said
yes, sir, Dr. Ananda,
yeah, you said non-progressive jaundice. How long you have followed the patient to say it is a non-progressive jaundice? You have seen only one visit, no? How long you have been kept the patient there? The ward?
2 weeks, sir.
So 2 weeks. 2 weeks. How many times you have done LFT?
Sir, I have done 3 days once.
But you didn't mention anything in the history, no? So clinically, when you say this is only a clinical history, okay?
Yes, sir.
From clinical history, what you are trying to do is you are getting the answer. From there, you are trying to backtrack and give a diagnosis straight away. See, this is why Dr. Manikandan was also telling it is better to say differential diagnosis. Don't ever say primary HCC or anything. Just give a differential diagnosis and leave with that. Any question is put forward to you, you can say further we will see the investigation. From there, we can come back.
Yes.
You understand? See, now what you are trying to do is you have more information than what we have, what you have presented. You have more information in terms of progressive LFTs, which we do not have. And you mean to say there is progressive, non-progressive jaundice.
Yes.
So that may be a one flaw in your presentation. Next one is, you said bilateral pitting pedal edema. And
Yes, sir.
again, you said there is no features of liver cell failure. Now, I would put forward like this, bilateral pitting pedal edema itself is a feature of liver cell failure. Number 3, as I said, it is better to give a differential diagnosis rather than giving a single specific diagnosis. Any epigastric mass, you just simply say liver mass. Liver mass could be anything. It could be benign, it could be malignant, anything. Number 2, you can always say pancreas and stomach based on the anatomical locations.
Yes, sir.
That would be a much better diagnosis at this stage, at only history and examination.
Yes, sir. Okay.
Yes. If I am wrong, sir can correct me also. Kaarthesan, sir.
Yeah, what you say is, I wanted to say that because this stage he has to give a differential diagnosis. And another thing, what I want to ask is, why are you saying that it is liver mass? Can you differentiate clinically between a liver mass and say that it is not a pancreatic mass or a stomach mass?
Sir, liver mass, clinically, the mass is occupying the epigastric region, and
Both
my fingers cannot
mass and stomach mass. Both all three will occupy the epigastric.
Mass moves with respiration, sir. Pancreatic doesn't move with respiration.
What about stomach?
Stomach will move.
Okay. So how do you differentiate between those? Clinically, I'm asking because a postgraduate, I'm asking.
You already answered this. You can answer one more time.
The presentation. That's why I'm asking.
If in case of stomach mass, upper bodies will be palpable, sir. In this case, my upper body is not palpable, and
there is
fingers
a
cannot be
extending into the fundus. Will the upper body be palpable?
And percussion impaired note will be here, sir. In case of liver mass, dull note will be present, and continuing with the liver dullness.
Yes, it is continuous with the liver dullness. 1 point. Another one, you mentioned that also.
Not able to insinuate your.
Not able to insinuate fingers.
In a stomach mass and a pancreatic mass, you will be able to insinuate your finger.
Yes.
That is the main 2 points. Okay.
Yes, sir.
And don't give this one like HCC blindly. You have to give a differential diagnosis. What Anand says is excellent. Go ahead.
Okay, sir. Yes, sir.
Okay, Jeyamohan, so how do you want to proceed in this case? We'll discuss a lot about management rather than going back now. So how do you want to proceed now?
Sir, to confirm my diagnosis, proceed with the investigation, sir. To confirm, I will take a liver function test and USG abdomen and triple phase contrast CT.
So you will do an LFT, yeah? You will do an LFT, yeah? And then?
USG abdomen to confirm.
You will do an ultrasound. Okay.
No, you finished all your blood investigations, one shot. What all you will do?
Ultrasound abdomen and triple phase contrast CT for
what
sir was asking blood investigation.
No, you finish all your blood investigations.
Routine blood investigation, hemoglobin, RFT, centrosuria and creatinine, liver function test, and viral markers.
Very good.
And then, if suspect tumor, also take tumor markers for this patient.
What tumor markers?
Alpha fetoprotein, and to rule out any other primaries, CEA and CA99 will take.
So every patient that walks to you, you are going to do all these 3 investigations, is it?
No, sir.
So as you said, there are 2 ways of presenting. One, you can say, I want to come to a diagnosis. Yes. For that, see, you said LFT, ultrasound, straight away you jump to CT, even without telling a renal function test. That is why I said do all the blood investigation. I didn't mean about the tumor markers at all. At this stage, in your MS exam, if you are going to say tumor markers, they'll be very angry with you now. So at this stage, what we would expect you to say is a complete hemogram, a renal function, sugars, liver function, coagulation profile, viral markers. That would do. You get your ultrasound. With this, you can get your CT. Next, based on whatever lesion, imagine there is no lesion in the pancreas or stomach. Why do you want to do a CEA and CA99? You would have saved a lot of money with that, right?
Yes.
So Jeyamohan, so always consider it as a real life scenario. So the problem here is you are so much biased now. You know the diagnosis and you want to go to the diagnosis. Just think that this patient is coming to you. So what all you will order? So you won't order a tumor marker first time when you see a patient. You won't even know. So there is a mass. So you will do this test and then you will do a scan. Okay, if this scan says so, okay, something in the pancreas, then you will ask further test. If this ultrasound shows a liver mass, okay, you will ask some other test. Okay, so depending on that, okay, so you'll tell first what you will do, and then with this I will go further. Then what happens is the examiner will ask you, okay, so this blood test shows this, ultrasound shows this. What next? Then you can go, okay, so you can tell about tumor markers here, you can talk about CT scan. Okay, so the main trick in the exam is you have to make sure that you don't know the diagnosis. You have to take the examiner. If the examiner knows that you are knowing the diagnosis, then they will start playing around you. Then it will be very difficult for you. Okay.
Yes, sir. Yes.
Okay, so you do the blood test, so basic blood test and an ultrasound scan, yeah. So
Yes,
from
sir.
the blood test, so from the complete blood test, from the complete blood count, what all information you can get specific to this patient?
Bilirubin values, sir.
No, from the complete blood count, CBC. So hemoglobin, okay, anemia, okay. So is there anything to do with the platelet counts in this patient? What if the platelet count is normal, or if the platelet count is say 80,000? What does it tell you in this patient?
Now you know the diagnosis, hepatocellular carcinoma. Now he says the platelet is low. That means there is some underlying chronic liver disease.
Cirrhosis.
Yeah. So it is a marker of portal hypertension. Yeah.
Portal hypertension, yes, sir.
Yeah. Which indirectly says that it could be a possible cirrhosis. Yeah.
Cirrhosis, yes.
Okay, so you do the blood counts, your renal function tests are fine. So you are doing an ultrasound scan. Yeah. So what is the motive of doing an ultrasound scan in this case? What are all you're looking for?
To confirm where the masks are arising from, sir.
Mm-hmm.
If it is arising from the liver mass, rule out other any other primary mass from the abdomen, stomach and pancreas.
If I may say, ultrasound is useless here. Am I right or wrong? Why do waste money on ultrasound? Straight away jump to a CT. See, remember, now you don't know the diagnosis because you are fixated with the HCC. You are stuck up here. Now remember, if there is a gallstones, your sensitivity of gallstones with ultrasound is 96%. Still, it is a simple jaundice.
Yes, sir.
Okay.
Yes, sir.
So I am wrong. So you need to do an ultrasound abdomen.
Ultrasound.
Okay. Now you have the blood investigations. Can you present them here? You have the typed or something?
I think he doesn't have the blood test reports.
Yes.
Do you have the reports attached, Jeyamohan?
No, sir. No, sir.
No. Okay. Or do you? I mean, can you give us a?
At least how much was it?
Do you have an idea of how much was it?
Sir.
Jeyamohan, only 10 more minutes for you, and then we have to go to Dr. Manikandan. So you have to be very fast.
Okay, Jeyamohan, I will give you the scenario. Okay, so fine.
Yes,
so
sir.
Your blood tests are all fine. Okay, your blood tests are fine in the sense the complete blood count is fine, and your LFT says that the total bilirubin is say 10. Yeah, the direct bilirubin is 8, indirect bilirubin is 2. Yeah, and all of the alkaline phosphatase is 350. All of the LFT markers are fine. Okay, and you're doing an ultrasound scan. So ultrasound scan shows that there is a 4x5 centimeter well-defined heteroechoic lesion in the left
Yes,
lobe
sir.
of the liver. Yeah.
Yes, sir.
Okay. And the liver, the rest of the liver looks shrunken and nodular. Okay. And there is moderate free fluid.
Okay, sir.
Okay. So how do you interpret this?
A single lesion, sir.
Yeah, so there's a single lesion, 4 centimeters, okay, which is in the left lobe of liver. The rest of the liver is nodular and shrunken with moderate free fluid. So are you happy with this scan? Is it leading to your initial differential diagnosis or not, or what? What is your thought process with this scan?
He said direct bilirubin is 8, indirect is 2.
This I cannot conclude with the diagnosis, sir.
Okay, so what all can you conclude in this? Okay, so LFT direct is 8 and indirect is 2. What does it say?
More conjugated bilirubin is more rise, sir.
Means it is an obstructive. So there is an
obstructive jaundice.
Yeah?
Obstructive jaundice, sir.
Yeah. So in the scan, you asked. Yeah. In the scan, you told about few questions that you wanted to know. Yeah. Tell me. Yes. Sorry.
If this scenario shows obstructive jaundice, there's no stones, and biliary system will be, if in case of normal bile duct and
no, I have told the ultrasound scan report. Okay, there is a 4 centimeter mass in the left lobe of the liver. So that was your first question you asked for. So where the mass is arising from, I have told it is from the liver. Okay.
Yes. Okay.
And the rest of the liver is shrunken and nodular. It means what? What does it tell you? Shrunken and nodular means
cirrhosis.
Yeah, it is cirrhosis. So
cirrhosis.
There is a mass lesion in the left lobe of liver with a cirrhotic background and with moderate free fluid.
Moderate fluid. Will give
Okay, so moderate free fluid here is no. So moderate free fluid here is what I'm indirectly telling is patient is having a mass lesion in the liver in a cirrhotic background with ascites. So this ascites could be because of a liver cell failure or portal hypertension. Yeah. Okay, so with this scan, what is your next test you want to do with this ultrasound scan?
I will do contrast CT abdomen.
Okay, so you have been repeatedly telling this. So why do you want to do a contrast CT scan in this?
Whether to confirm this is primary or secondary.
Okay, so how do you confirm it is a primary or secondary?
In secondary always bilobar involvement and multiple, sir.
Okay, so you told that it is probably HCC. Okay, so I think
yes, sir.
Now, from the ultrasound itself, from what he has given information to you, I'm still telling it is a pancreatic mass with a secondaries in the liver. So how do you differentiate? You said CT to see whether it is primary or secondary. I am giving you a second differential diagnosis. That is a small pancreatic mass causing obstructive jaundice, and there is a secondaries in the liver. See, when you say CT, say triple phase CT.
Yes, sir. Hello.
Yeah.
Can you hear?
So, yeah. Yes, sir. Sir was telling about triple phase CT.
So why do you want to? Yeah, we can hear you. So why do you want a triple phase CT? So when your primary diagnosis is HCC, and when you are telling repeatedly triple phase CT, can a triple phase CT confirm whether what you're dealing with is HCC or not? It can or not?
Yes, sir.
Okay, what finding in the CT scan will tell you that it is a HCC?
Sir, it's a hyperosculation, so it's a increased uptake in arterial phase and early washout in venous phase.
Very good. So that is what you need to tell. So that is the reason why you do that is why we call it as triple phase CT. So what are the triple phases in the CT scan? What are the triple phases which we tell?
Arterial phase, venous phase, and delayed venous phase.
Yeah. So what we need is a dual phase for HCC. So we need a arterial phase and a portal venous phase. So the HCC, in the HCC, the lesion will be hyper enhancing in arterial phase and it washes out in the venous phase. So this itself is more than enough to tell what we are dealing is with HCC or not. Okay. Yeah.
Yes, sir. Yes,
okay.
Sir.
So say if this CT is showing such a finding, okay, it is showing that the lesion is enhancing and it's washing out, suggestive of HCC. What next? Is that enough for you to confirm the diagnosis, or do you want to do a test or a biopsy or something else?
This is enough, sir. No need for biopsy.
So CT scan is enough.
Yes, sir.
Do you need, so you need basically at least two things, okay? One blood test under CT scan or two imaging, yeah? So in this case, if I ask you to do a blood test, what test you do?
Alpha-fetoprotein.
Yes, so here comes the alpha-fetoprotein, okay? So you do an alpha-fetoprotein levels, and if it is elevated along with the CT scan showing this finding, then it is HCC and there is no need for you to do any biopsy, okay? Say, for example, AFP is elevated and in your CT scan, it is not showing the characteristic feature of a HCC. Yeah. What will you do?
You will do another image, MRI.
Very good. So you can do an MRI or you can even biopsy it. Yeah.
Yes.
Okay. Fine. So, so in this case, what do you like to do? What do you want to do? How do you manage further this patient? So you have got the diagnosis of HCC, yeah, and I have told that the liver looks cirrhotic.
Yes, sir.
So how do you want to manage?
Assess the liver function, sir. If it is resectable with the adequate functional liver.
No. Wait. What is the size of the liver tumor?
In this case, 8 × 7 centimeters.
8 × 7 centimeters, which is a very big tumor, right?
Big tumor.
What is the total? What is the total liver span of this patient?
So you're told it's 16 centimeters. Yeah.
16 centimeters. Yes, sir.
So, 16 centimeters by CT. You mean to say 16 centimeters by the CT? Is it? In between, I missed
clinical
So you told the liver is palpable 16 centimeters from the subcostal margin. It means it is so
6
huge.
Centimeters. 6 centimeters from subcostal.
Okay.
But he said the liver is shrunken. The liver was a nodular. By CT wise, you need to see how much is the liver remnant there. You're going to go for liver resection straight away. So you need to see the volumetry before jumping and saying hepatectomy.
Yes, sir.
And when you say 8 centimeter, does it fit into any other criteria? What would be the best? What would be the best treatment for cirrhosis?
What's the cure for cirrhosis? What's the cure for cirrhosis?
Transplantation.
Yeah.
Liver transplantation.
Yes. So
you should consider a chance if this patient will fit into as a candidate for transplant or not. That should be your first aim before saying some other treatment. So how would you say this patient will be fit or will be fit into the candidate for a transplant?
Sir, Milan's criteria.
Oh, wow, wonderful. Very good. Good.
This single lesion less than 5 centimeter in size or 3 inches less than 3 centimeter in size with no lymphovascular invasion. If we can do transplant for this patient.
Good. Okay.
So your criteria, you know, that should be more than enough. You don't have to tell everything because there is something more than Milan. Beyond Milan, there is something called UCSF criteria, wherein even up to 8 centimeters they can go on transplant. So this patient will ideally fit into a transplant rather than doing a hepatectomy.
Resection.
But before saying transplant, what would you do?
I'll do staging of the disease. Barcelona, according to Barcelona liver cancer staging.
I think you know more than us now.
Yeah, so very good. So what you need to do is, so the initial management is, how do you decide on transplantation or resection is, you should know the functionality of the liver, okay? If the liver function is good, so basically you categorize into child A, B, C, okay? In a child A patient where the functionality is good, you can still consider resection, okay? So any late child B or child C patient, there is no role for resection. For that matter, leave the liver resection. So in a child C patient, even if you go and do a hernia repair, again, the risk of life is very high. So patient will end up in liver decompensation and die. So in a HCC, if you are dealing with a child A liver, okay, child A, good functional liver, and if you think that there is a good remnant liver volume, you can consider both, either resection or you can go for transplantation. In a late child B or child C, you have only option of transplantation, provided it lies within the criteria of Millen or UCSF criteria. If it is anything beyond the Millen or UCSF criteria, there is no cure for this, and patient will come under palliative care, which involves all other options like doing an radiofrequency ablation or a chemoembolization or a radioembolization, or things like that. Okay. So this, in general, this is more than enough for a general surgery postgraduate to know, actually.
But during your course, did you say endoscopy as your investigations? What is the role of endoscopy in this? You never said a word about endoscopy.
Sir, to rule out other primaries.
So your CT scan has already diagnosed it as HCC. Do you still worry about the stomach primary or something? Why do we do an endoscopy in any liver patient for that matter?
Where is his bleeding? Portal hypertension. Where is the bleeding?
Hypertension. Yes. So when you have a liver, say in this patient, if the CT scan shows us it is a normal liver with this lesion, okay, even in that patient, any patient whom you plan a liver resection, you should do an endoscopy, because there could still be a subclinical portal hypertension, which can affect your outcome. So even if the liver looks normal in the CT scan, you should still go ahead and do an endoscopy to look for evidence of portal hypertension. And if the patient has portal hypertension, again, that will be a very strong contraindication for any major liver resection.
Okay, sir. Yes.
Is there any role for laparoscopy before proceeding to liver resection? As part of your staging workup, you are planning for a major liver resection. You think the rest of the liver is good, so you think that should be enough. Can the peritoneal mets be picked up by your routine CT?
No, sir.
So if at all you are going to go for resection, I think a better diagnostic laparoscopy can be helpful.
Yes, sir. Yes.
So both the criteria which you mentioned for transplantation, the most important criteria is there should be no extrahepatic disease. Okay, in order to rule out there is no extrahepatic disease, you have to either do a PET CT scan, whole body PET CT scan, or a diagnostic laparoscopy. Again, in a PET CT scan, picking up a peritoneal metastasis by a PET CT scan is not that great, actually. So diagnostic laparoscopy is best. Many times patient who's taken up for transplantation for HCC, they'll go in, they open, and then they come out without operating also. You will find a peritoneal disease. So I think at least at your stage, I think it's better to tell diagnostic laparoscopy, maybe a PET scan, yes. So you have to rule out there's no extrahepatic disease.
Okay.
Okay, good.
Dr. Kaarthesan and Dr. Anand, is there any more questions?
No.
I think I should congratulate Jeyamohan first of all. It was a fantastic presentation, and the knowledge which
Thank
he
you, sir.
shared about management is phenomenal. From my side, a single small advice is try to take your examiner to the route which you want. Don't give any answers where he can start questioning you, as Dr. Anand, Dr. Kaarthesan, and Dr. Manikandan was telling about when you are presenting on the summary. You should not have a fixed brain, or you should not convey that, show any signs saying that I have already come to a conclusion. So it should be always open, and try to give answers where he will always come along with you. So that other than
Yes,
that,
sir.
it was a fantastic presentation. I think I hope everyone agrees to that. So
Yes, sir. Thank you,
thank
sir.
you, Dr. Jeyamohan. I think you can
Yes.
stop your screen share. And I'm
Yes, sir.
making Dr. Manikandan as the co-host now.
Have you?
Yeah, I think people are waiting for your talk.
Yeah. Okay.
And thank you, Dr. Kaarthesan and Dr. Ananda Kannan, for taking up this moderation, even though online, and at the last moment it is and with shared your questions with Dr. Jeyamohan. I think more postgraduates should come up and present in such a forum where stalwarts of each field will question you, and you will get confidence to present. Because we all were exposed when we were postgraduates to all gut clubs, all the IA, GES, ASIs, and we'll be ripped apart by 20 to 30 people. And those gave the confidence for us to boost it up. So thank you, sir. And over to Dr.
Thank you for the
Manikandan.
invite, Raj. Thank you.
Thank you, sir.
Rajavel,
Thank you, sir.
can you see my slides now?
Thank you, Raj.
We are able to see your, thank you, sir. We are able to see your slides, Mani. We are able to see. I think you have to press the presenter mode. That's on
Where
your
is it?
top left.
Press
Top left.
F5.
F5. Yeah.
So can you hear me now? Can you see my slide, first slide?
I'm seeing your slide as well as the all the slides on the background.
Oh, is it?
I mean,
Okay,
yeah. Or you just come out of it and share your screen and present. That makes more sense.
okay, resume share, yeah.
Yeah.
Is it okay now?
No. I think now it's okay, but still we are able to see your. Yeah, now it's okay. Now it's perfect.
Yeah.
Yeah, now it's
But
perfect.
why am I not seeing any of your? I'm not seeing
There will be
what to say.
Videos. I mean, the participant videos.
Manikandan, when you are going to present, you will not see any of us. You just think that we are there. Imagine.
Okay, fine. Because I
no,
that's
you can.
okay.
You can select. There will be a small viewer somewhere in the bottom.
But it was there in the evening. But it's fine. It's okay. That's okay. That's fine. Right. Okay. So this topic is predominantly for the young surgeons and junior doctors in this group. Okay. And first of all, thank you, ASI Trichy, for giving me this wonderful opportunity to interact with you all. And for the next 40 of it, I just have 20 slides on this, and I'll be speaking more, and it's very, very informal. For the next 40-45 minutes, I'll be telling about some basic guidance about how and what are all the pathways for the surgical trainee or a young doctor from India to move into the UK, if at all, if you think that you want to have any kind of surgical training in the UK. So I am Dr. Manikandan Kathirvel. I work at the Royal Free Hospital, London, and I am a senior clinical fellow in HPV liver transplant surgery at Royal Free, and I am NHSPT accredited lead National Organ Retrieval Service, multi-organ retrieval surgeon, and I'm giving this service to Royal Free Hospital, London for the last 2 years. So I've been in the UK for the last 3 years. Yeah. So before going into the topic per se, I would like to tell why this topic and why me and Rajavel chose this topic. The main reason is we are in a situation or an era where any doctor who is a budding doctor should subspecialize in some core area in their practice. We have crossed the era that we have no more a general surgeon, no more a GI surgeon. So we should become subspecialized in a particular area, at least in the next 5 to 10 years. Even things in India will be changing. So, with this background, the options or route to get subspecialized in those areas is becoming more and more difficult, and it's more and more becoming competitive. So every one of us should know what are all the options available elsewhere, so that if that suits you, we can go and take. So that's the main reason why we thought, okay, what are all the options for an Indian surgeon to get trained themselves in the UK as a topic for this forum. And to tell upfront, this is not an advertisement or anything. It is just a guide or what I knew and what I encountered when I tried to move into the UK 3 years back. I'm just giving a guidance or a note to the young doctors in this group. So the objectives of my presentation will be, first I'll be telling about why doctors generally think that they want to move into the UK. And I'll be telling about the advantages of a UK training in my perspective, and what are all the basic requirements for any doctor before they decide that they can enter UK, and what are all the roles or options available to take up when they move into the UK. And at the last, I will tell very briefly about what is a lifestyle in the UK and what are all the drawbacks and some take-home messages. So first, to start with, why UK training? So in the last 3 years, I had received at least say 50 to 60 phone calls from medical students, postgraduate doctors, and even senior surgeons from India asking for options for entering the UK. But when I asked them, why do they want to come into the UK? They give plenty of reasons for that. And most common reason among that is they all think that coming into the UK gives them opportunity to focus on a particular area, which is right. And they all, to some extent, know that majority of the centers in the UK follow protocol-based treatment, and they would like to master this protocol-based treatment. Some feel that coming into the UK will strengthen their CV, and some come here to do the research. And from the financial point of view, people think that once you come into the UK, they get better job opportunities and more salary. And few come in with an intent of setting into the UK, liking the lifestyle of people living in the UK. And some just come in because of peer pressure, just because a friend has gone into the UK, they just want to come in and have that tag to attach to their name. And many tell this, they tell that they're not happy with the Indian system for whatever reason. One, because of the job insecurity, which I see mostly after this COVID scenario. And other system is they don't get enough training or whatever, which the candidates say. And the young doctors, they tell that difficult entrance exams for them to cope up, the Indian entrance exam, that's the NEET exams, and many don't have any reason, just like that they tell, okay, I would like to come into the UK. So these are all the common reasons which any doctor or a surgeon who wants to come into the UK put forth before they come in. But having lived in the UK for the last 3 years and working in the NHS doctors, in my perspective, what a UK training or a UK career gives you is, it gives an extremely focused training. So unlike hospitals in India, where majority of the hospitals provide all kind of service, here the hospitals are segregated into 3 things. One is a district general hospital. We have regional referral centers and specialist centers. So district general hospitals are there once in every 50 to 60 miles, which offers all kinds of basic treatments. And if there is anything beyond their limit, for example, even any kind of cancer won't be handled in the district general hospital. So, so all those patients who require any special care, including all kind of cancers, will be referred to the regional hospitals, which handle only these referred cases. Similarly, we have very specific focused specialist centers in the UK, which handles only very specific diseases. For example, the liver transplantation is provided only by 6 trusts in the UK. If you see pancreas transplant, it is provided by 3 trusts in the UK. If you see bowel transplant, it's given by only 2 hospitals. Apart from the transplantation field, if you take, say, a focused thing in the, say, an upper GI, in the upper GI, we have 2 or 3 centers which specifically provides robotic esophagectomies. We have specific centers which handles only the motility disorders of esophagus. We have special centers for oncoplastic breast reconstruction centers. We have specialized centers for inflammatory bowel disease. We have specialized centers just for pelvic floor disorders. So all these hospitals are segregated and the cases are just referred to these centers where they are managed. So if you want to train yourself, or if you want to master a particular area of your field of interest, I think UK is best in that. So you go into the hospital, you stay there for 6 months or a year, you will become a master in that. So that's the main advantage which I think the UK career gives you. And the second important thing is you will master the MDT approach. That's nothing but the multidisciplinary team approach. So all the treatments and decision plans, whether it is a benign or a cancer, always goes through an MDT pathway where the cases will be discussed and a collective decision is made. So this gives an opportunity for the doctors as well as for the patients for a better outcome. And the most important thing which we all lack in the Indian scenario is the communication skills. So the practice in UK, starting from the exams which they conduct to enter the UK, they give more importance to maintaining confidentiality and the communication skills. So starting from the clinic appointment with the patient and getting the consenting, we spend more time talking to the patient and developing relationship with the patient and gaining confidence from the patient, which is again more and more important, at least for the budding surgeons now, because the era of telling the doctors are God is gone. So now, in order to safeguard ourselves from any kind of medical legal problems, we need to be very, very open to the patient. We need to tell everything. So I think your training here in the UK will give this skill enough, and then it opens up the global opportunity. So if you get trained in the UK, your options across various centers in the world opens up. So for example, your training in any kind of training in the UK is recognized by Singapore, recognized by Australia, and majority of the European countries. So it gives you an opportunity for you to go and work in multiple areas. And then the most important thing is, although I don't practically feel that this is true, I'll see, from my point of view, the training which we have in India, or the practice which we have in India, or the skills we have in India are the best. There's no superior thing in the UK, but unfortunately, your 6 months job in UK or 1 year job in UK adds more strength to your CV than whatever degree you get in the India. And again, the unhappy thing is, except for our MBBS degree, which we get in India, the MS or MD or MCH, none of the degrees are recognized in any other major universities across the world. But your training in the UK, or your basic, say, an MRCS exam, gives you, opens up your gate for most of the countries in the world. And then the most important thing is you will have an opportunity to do very quality research. You can get some very good publications, and you will understand the importance of audits and doing an audit. Again, even if you go back to India, we are all slowly moving towards this era of seeing what we have done and how to improve ourselves by seeing our own results. So the concept of audits is still coming up even in India. So this gives an opportunity of learning how an audit is done, how an audit is interpreted, and how an audit is executed. And the other thing which I felt fascinating is network building. So UK is a hub where doctors from many countries come and work. So you develop friendship with many people here. You get opportunities to travel around. You get opportunities to know the culture around. So for example, I had an opportunity to go to Cyprus for 2 weeks, an observership through one of my friends. So network, it gives an opportunity for network building. And it's a completely different health system where everything is prioritized. So if you have a cancer, you get your treatment quickly. But if you have a benign problem, you have to wait. And whoever it is, whether it's a rich or a poor, or you have influence or not, everyone are treated the same. Whereas, just for a small example, so I took my kid to the A&E of my hospital 3 weeks back because she fell down and had a problem in her foot, in her hand. So they didn't even recognize me as a worker there. So I waited for 8 hours for a doctor just to see, and then another 4 hours for an X-ray. And then by the time I came out, it was 16 hours for me waiting in the A&E. So everyone are considered equal. Yeah. So this is all we get when we train ourselves when we come into UK. This is from my perspective. Again, it's a good lifestyle. Means I wouldn't say good lifestyle, but it is a different lifestyle of what we have in India. It is a bit stress-free, and you have a fixed time job between 8 to 5 or whatever, and beyond that, no one is going to disturb you, and you have a reasonably a good income for, especially for doctors, to have a good, reasonable life here in the UK. Okay, so with this background, so before you decide that, okay, let me try UK, let me go into the UK and see what this country offers to me, you should answer all these questions. Without the answers to all these questions, you cannot decide what pathway you should choose. So first of all, what you need to know is how long you are planning to move. Sorry, Will. Hello? Can you hear me?
Mani, sorry, it was Dr. Rajiv Raj, not senior. I welcomed him and I muted him. We are clearly hearing you, Mani.
Okay, fine. Okay, fine. So before deciding to move into the UK, so the things which we should answer to ourselves is, how long do you want to stay in the UK? And what is your purpose? So whether your purpose is to go train in a particular area, or you want to go and experience a different health system, or you want to go and have some lifestyle with your good quality family time, or you want to settle down in UK. So you should know what is your purpose. And the most deciding factor in this is, how is your family adjusting with you? So are you going alone, or you will be taking your wife and kids? How many kids you have? What is your support your family has? So these are all the factors which will make you decide whether you can do this or not. And then the most important thing is, you should have contacts here. So getting a job into the UK does not come with just your paper. So you should have contacts here in a particular. So if you're applying to a particular hospital, if you get to know a consultant there or any working person there, it is easier for you to get into the hospital rather than just waiting, applying for the post and wait for what they say. So you should have, if you have good contacts, the chance of you getting a job in a good center is much easy. And similarly, you should know what is your strength. Just because you have done your MS or an MCH, it doesn't mean that you are confident enough in doing whatever skills you learned. So if you think that, okay, if your skill is less for a general surgeon after passing an MS, then you should select a particular kind of a job which will help you building that. So as I mentioned you before, all these centers are very specialized. So if you take a specialized center, say if you take a senior clinical fellowship post in a particular hospital, they will expect a minimum requirement from you. And if you don't give that, you will be neglected in the system. So you should know what is your strength and which level of post you can apply for, or which level of training you can get in for. And similarly, the last thing is, what is your long-term plan? Again, it's a very difficult question to answer. People come in with the mindset of going back within a year, but you come in, stay for 3 years, 4 years, and then people stay here. But at least you should have a rough idea of, okay, whether you want to come back to India or stay here or make further plans. So this is all the questions which you should answer before you decide to go into the UK. So now the next few slides will be concentrating only on what is needed to enter the UK. Okay, so the basic eligibility to enter the UK, either for training or settling down or whatever, in the medical profession, is you need a General Medical Council registration. It is like an the Indian Medical Council registration or Tamil Nadu Medical Council registration. This is called the GMC registration. Here the difference comes between the US and the UK. So in the US, so whoever it is, whether it's a super specialist trainee or whatever, you need to write your USMLE exam, and from there things get diverted. But in the UK, there are multiple ways through which you can get the GMC registration. And these are all the four common ways through which you can get. And the most common thing is the PLAB exams, which is the most common route, which very young doctors like, say, MBBS students who come into the UK, they take up, and very few postgraduate students also take up if they think that their Royal College exams are difficult. And the second thing is the Royal College exams. So for surgeons, the MRCS exams. So once you clear the MRCS exams, that gives your green light to apply and get the GMC registration. So that's the reason why I did my MRCS exams in 2014. Thinking that if at all, if I plan to go into the UK in the future, I will use it for my GMC registration. But to be very frank, except for surgical specialty, all other specialty like pediatrics or radiology or medicine or whatever, they prefer to do PLAB exams rather than their MRCP or MRCPH or whatever, because their Royal College exams are much, much difficult. But from my point of view, the MRCS exams are much, much easier than PLAB exams. And the third thing which comes here is the MTI. So MTI it's a question which many of the doctors call me and ask. So MTI stands for Medical Training Initiative, which is an initiative made by the Royal College, where they give temporary registration for 24 months. So you need to apply directly to the Royal College, and they will so they will consider your application and they will give a temporary GMC registration just for 2 years, and they will give you placement. So you come in as a fixed time contract visa, you come into a specific unit, you work here, and you have to go back in 24 months. So this is called Medical Training Initiative, and for this, no PLAB exam is needed, no Royal College exam is needed. And the last year, at least 60% of the MTI seats were occupied by the Indian medical graduates. So this is one of the good opportunity for any Indian medical graduates who just want to come in for a fixed period of time, do it and go back. So MTI is an option. And the final thing is a sponsorship, which is extremely unlikely to happen. So if, for example, if you know any very senior consultant in any of the trust here, and if he is happy to sponsor you in the sense, if he is happy to give in writing telling that your training in India is in par with the local trainees in the UK, then the Royal College can consider those applications and they can give a permanent registration under GMC, but it's very, very, very rare. And as I told you, you should have very, very strong links and contacts to obtain this sponsorship. So this is about GMC. So once you clear any of these examinations, and for the GMC application, it's not just the examination which is needed. What else is needed is you need to clear IELTS exams. Again, the IELTS exams comes in various modules, and the module which we need to take if you want to practice here as a doctor is IELTS UKVI Academic. This is the exam which you need to take. And again, from my point of view, and this is the opinion which I got from many of the doctors, IELTS exams are much, much difficult than MRCS exams. So to be very frank, I failed 3 times before I got clearance in my 4th test. So again, all these exams are very, very costly. So the major hindering factor or your time limiting factor in your GMC applications will be the IELTS exams. And the second thing is ECFMG or the EPIC. So basically GMC doesn't accept our MBBS just like that. So they had outsourced this to the ECFMG association, which is in the US, which does the job of approving that our basic medical qualification is genuine or not. So you need to open an account with these guys, and we have to apply our MBBS degree, and they will verify whether our MBBS degree is a genuine degree or not. So these are the 2 things, again, which is a late limiting step. But these two things are the ones, if say an MBBS doctor or an MS postgraduate who sort of strongly has the feel of going into the UK, they can do these things whenever they have time. So they can do this and make things cleared up. And for the IELTS exams, once you clear the IELTS exams, you have a duration of 2 years to use this marks. And then you should have references for GMC application. We need at least 3 references, very strong, good references, preferably from your unit chiefs. And if possible, if one of these references had a previous UK training or a previous active GMC registration, then that adds more. And you should have a basic medical degree, which will be our MBBS, and the gaps in the employment. So the GMC application itself is something like a 30-page booklet which you need to fill. And they consider very seriously if you have an unexplained gap in your training or employment. So you should be very, very careful when filling this. If you have a gap of more than 6 weeks, you should be careful in explaining why. And the most important thing with any kind of UK things, you have to submit enough evidences to tell that you are very genuine. And along with that, you should have PLAB and Royal College exams and MTI sponsorship. So these all are the basic things which you should have before you apply for GMC registration. The most important thing which I would advise the young graduates here is, when you fill up the application forms, it is always advisable to speak to some person who knows this, because even a small error or small issue with the application, if there is a rejection or if they send the application back for verification, it takes so much time. The normal processing time for GMC application, at least during the pre-COVID period, was somewhere around 2 to 3 months minimum. And if you have problems, then it all delays up things like that. So if you are really thinking that you want to do this, speak to someone who has already done and get help out of that. Okay, so once you get the GMC registration, what next? So what are all the roles available for you? So these are all the roles which you see the people from the UK tell. They might tell that they are the deanery training. Some tell you that they are an SHO. Some tell you that they are a junior clinical fellow, senior clinical fellow. Some tell that specialty doctor, specialty registrar, and there are some named fellowships. So these are all the various roles which any trainee can take, any trainee or a training person can take. So the first thing, trainee, is basically like India. It is like a structured training program where people do a foundation year training. Foundation year training is like our internship. And once you finish your foundation year training, after our internship, you apply to enter the surgical specialty, and then you enter into this core specialist training, which is the core surgical training, which is for 2 years. And again, you need to apply for something like, if you want to go into a specific specialty, after the end of 2 years, you apply into it, and then you enter the specialist training. So this is exactly the duration of what we have in India. So for example, after the medical schooling, we have an internship of 1 year, but here this internship period is something like 2 years. And then, so I would say the core specialist training year 1 and specialist training year 3, we can consider it as something like an MS or an MD, and then comes like the MCH or the DM, and then some training. So this is the minimum duration of training which is required before you reach what is called as a CCT, which is called as a completion of training. So completion of training. So once you finish CCT, you will enter into something called as a specialist register. So only when you enter into the specialist register, you are eligible to become a consultant. Okay, so this is the curriculum which I had put up for the surgical specialty. If you want to go into any other specialty like a cardiothoracic surgery or plastic surgery, you have something called as a run-through program. After your medicine, you give your exams, you enter year 1, come out at year 8 as a CCT. So you don't need any of these breaks. But if you want to do a general surgery or an internal medicine training as a proper trainee here, these are all the things. Again, so in what way you can enter this training system? You can write either PLAB exam and enter the foundation year, or if you had done an MRCS from India, and if you have competency signed for all these 4 years, you can straight away join ST3. And from ST3, you work for 5 years under some specialty, and then you get your CCT. So here comes the FRCS exams. So in the UK, for entering, so at this point, from after the core specialist training, to enter the specialist training, you need MRCS. So without MRCS, you can't enter the specialist training. Similarly, before you complete your core training, that is a CCT, you should have FRCS. So that's the reason why I have both MRCS and FRCS, and every trainee, surgical trainee from the UK, they will have both MRCS and FRCS. So MRCS is the entry exam and FRCS is the exit exam before you complete your surgical training. So in this way, this is a very, very safe way, and this is the way I would advise people to take if they don't have a fixed duration of stay in the UK. If they say if they're happy to spend 5 to 6 years in the UK, they should take up this way, because the advantage is at the end, you will reach the CCT easily, you will enter the specialist register easily, and then you can become a consultant easily. So this is the trainee pathway. And the second pathway is the junior or the senior clinical fellowship. This is the most common kind of a module which is taken by the international medical graduates if they want to just spend 1 or 2 years in a particular field, train themselves and go back. And this is the reason why I took this post. So I took the senior clinical fellowship post, which is equivalent to SG8 or a senior registrar of the local training. So this is, so it is in, if you take the UK hierarchy of work, so senior clinical fellowship just comes just beneath the consultant level post in the UK. So the junior clinical fellowship means junior clinical fellowship is something like a post which say a general surgery trainee or a post MBBS doctor can take, and the senior clinical fellowships of those fellowships which can be taken up by specialist trainees, or say a general surgeon who had worked for 3 or 4 years, they want to come in and take a particular specialty here. Again, these posts are very, very temporary posts. It comes as fixed contracts. So, and the minimum contract for these kind of jobs is 1 year. And you come here and you will get a visa sponsorship for 1 year. You work for 1 year and go back home, or you can get another job and go. So this is the most common pathway which majority of the Indian trained surgeons or the surgeons who come here take up. And to access the jobs, the most common websites use is the track jobs or the NHS jobs. So you go in, you fill in your details, you can fill in what kind of job you look for and in what specialty you look for, and you will be notified every day. And whichever you are interested, you apply for it. Again, as I told you before, you should have a GMC registration before doing any of these things. And I can tell you that the job opportunities are too much in the UK. There's no difficulties in getting any kind of job, whatever you want, depending upon your skills. But only thing is you should have a proper contact, and you should know the technique for getting the GMC and technique for filling the application forms. So all these application forms, whichever comes, again, it is a package of say 15 to 20 pages. You need to fill so many things, but again, the technique matters, because when they shortlist these applications for the interview, they have separate points for each section of the application, and they give weightage for specific things. So majority of our candidates who they call me telling that they have been applying for all the posts, they have not even called for a single interview. But when you go back and see their application, it will be nothing. So they should know what they are looking for in the application. So if you are a first-time applicant applying for any kind of job in the UK, I would advise again to get or speak to someone in the UK or someone who has had this experience before, get their advice on this and go. Similarly, again, the interview pattern. So once you are shortlisted, once you are invited for the interview, again, they have a specific set rules of how the candidate will be evaluated on the day of interview. So again, it's always better to speak to someone, get some learning on how to attend an interview in the UK, and then go in. So and these things are not difficult at all. It's so simple. That's why I tell that. So if you are finding it difficult to get an MCH or a DM post, I sincerely advise you to take up any of these fellowships, come into the UK, and I can promise you that you will be considered better than an MCH candidate or a DM candidate once you go back home or you go back to any other country. So after all these things, so these are all the options, again, as I told. So if at all, if you decide to settle down in the UK and if you want to become a consultant, there comes the problem, because the system here is set so easily for people to come in and train. But when the thing comes as for consultant, they are very, very, very stringent, and there are so many rules which comes in, and they give more priority to British candidates and the European Union candidates than non-European Union candidates. But still, it is not impossible, yeah. But again, if you have the thought process of becoming a consultant or settling down here, the best way is to take the trainee route. So take this trainee route and then finish your training, and you get your CCT, and then you can apply. And there is another route called CSER. So something like, say, for me, who has done so much of training back home, I don't want to come here and start my training again. So they have an option, something called CSER, where I can give enough evidences to the British Council telling that I have enough evidences equivalent to a trainee who completed their training here, and they might consider the application and they can award me a place in the specialist register. But this process is very, very, very tedious, and the success of this process is very, very minuscule. So if you have a long-term plan of settling down here as a consultant, the best way is to take the trainee route. And as I told you, the MTI stands for Medical Training Initiative. And if anyone is interested in this, you just type in Medical Training Initiative. That gives enough information about how to apply, what are all the options available. And as I told you, this scheme doesn't require you to clear lab exams, doesn't require you to do MRCS exams. You can select specialty. Say, for example, every year, a candidate from Madras Medical College comes into King's College to get 2 years of training in liver transplantation. So something like that. All the specialties are available. Whatever specialty you want, you can apply and you can get it done. And this comes with just a temporary registration. You will be given a GMC registration for 2 years, and at the end of 2 years, you have to go back. So this all in an overview about what are all the ways through which you can come in and what was the career options in the UK. So I have not gone in detail about what is PLAB, how MRCS is written and things, because each one it's a topic by itself. So I'm just giving an overview. So the next thing which I want to tell is, okay, having got a job, the next doubt which all have is how is the lifestyle in UK, how easy it is to live in the UK. So from my point of view, any post here is well paid. So an FY1 doctor here or an internship doctor here is paid at least £2,800 a month, which is equivalent to 2.8 lakhs. I can tell you that the cost of living here is very high, but still this is more than enough for you. So for me, say I am a senior clinical fellow, if I get a £5,000 a month here in London, for me, the expenditure is somewhere around £2,500 a month, and still I could save like and this is with me and a non-working wife, and I have 2 kids here. So you have a good pay. And then if you want to make even more money, you have something called locum shifts. These are all the vacancies which is available every day. You go to various hospitals, you do some shift, and you will be paid like anything. For a basic example, if you are doing an SHO job or an internship job in a department for a night, you will be paid something like around £250, which is like 25,000 rupees per night for a 10-hour job. And then the other lifestyle is it's a fixed time job. So you go on your fixed time of your duty and you do your work properly. It is not like you can scoot there. Your work will be monitored. There won't be any place to sleep. I can tell you that, because the night shift persons are not expected to work in the daytime, and during the night shifts, they're expected to work. And there'll be a constant surveillance of what we do and what we are doing. And if you are coming here with the children, you have schools which very, very good schools in par with a very costly school in India, very good schools which is completely free. Your healthcare is completely free. And if you're bringing your wife as a dependent here, they can work as anything except for a doctor or a dentist. Still, if your wife is a doctor or your husband is a doctor, they can do locum shifts and they can get paid. And UK has a very good connectivity to India. So this is in gross about the lifestyle in the UK. But what are all the drawbacks? So everything comes with a pinch of salt, So the drawbacks is the initial thing, before entering the UK, you need to invest some money, The IELTS exams, each exam costs something around 30,000 rupees. And as I told, unless you are a very smart or a very good guy in an English, it is so difficult to pass the IELTS exams in the first attempt. So you'll be spending at least like 50 to 60,000 in your IELTS exams. And then if you want to clear your PLAB exams or MRCS exam, which comes to around 1.5 to 2 lakh, and then GMC registration and your travel. So before you start your work, you will need a minimum of 3 to 4 lakh rupees to come in. But you will be paid enough. And then the processing times for everything, starting from your GMC application or your exams, everything is too slow. So from the time you apply for a job and you get a job here, it takes at least like 8 months to a year. And then the interviews, I wouldn't say difficult, but for candidates from India who don't have this interview kind of a system in India, because we all go with exams and marks, we don't have interviews. So we need some kind of training, and we need to know the techniques in these interviews before we apply apply for this. And then the fourth important thing, which everyone suffers here, is no support, you know. So me being here with my family, I have to look after everything. I need to look after my home. I need to clean my toilet. My wife has to do this, and I don't have many elderly support or for my kids or something. So you will be helpless here. So these are all the drawbacks which I want to put up. So the take-home message which I want to tell every young graduates here or the young doctors here is, you should keep your options open, yeah, because as we move on from here, the competition is going to be more and more severe. So you need to win the race, and you need to showcase yourself that you are a specialist in a field. So keep your options open, and whenever you get time, try to verify your basic medical degree with ECFMG, which will be very useful. And I would advise all the surgical postgraduates to clear their MRCS exams, not only to enter the UK, but it gives the chance for you to enter any country, majority of the country where you want to say. Singapore recognized MRCS, Australia recognized your MRCS degree. So most of the, even China, I think Hong Kong recognized the MRCS degree. So your MS degree is not recognized, your MCH degree is not recognized. So clearing MRCS gives you weightage in your CV. So it opens up your options. Similarly, there are many institutes in the country which pays more salary for an MRCS pass candidate from a non-MRCS pass candidate. Similarly, in the Gulf, you will be given more preference if you have an MRCS degree. So basically, MRCS is nothing but it gives you an international certification that you are a skilled and a safe general surgeon. That's what it says basically. And then try to get help and guidance from seniors who have already done these things. And my most important advice is never waste years in your training career. Try to finish or reach your goal first, and then try to train wherever you want. Don't waste time telling that you want to do this or that. It's not going to add you anything. And try to build your CV from your early part of your career. And again, as an Indian trainee, we all lack in publications, research and audits. At least now it is good to see that many private institutes and hospitals are coming up promoting or helping the students in doing publications and audits. So try to do these publications, few publications, try to do quality research, try to do audits. So all these things adds up too much to your CV. And when you go out of India, these things gives you a lot of rewards. And similarly, whenever you have time, attend attend courses on research methodology, teaching techniques, leadership courses, basic life support, and ATLS. So again, these courses gives you many points for you to score when you come out of India and when you apply for any kind of jobs. So this is all about today's presentation. I'm very happy to help, and me along with a few of my colleagues who are here, we have been doing these jobs in the form of guiding people in the MRCS exams, helping them to write their CV, helping them writing their applications, helping them how to attend the interviews and things like that. So I am very happy to help you. And this is my contact number. You can contact me in WhatsApp or Facebook, or you can email me, and I'm very happy to help you. And I think Rajavel would have recorded this presentation, and I would advise him to share this in a forum where young doctors can access it. So I have not gone through in detail about all those things, but I have given you an overview about what is what. Yeah.
Yeah, Mani, I have recorded it, and we'll be circulating the YouTube link of the entire presentation and the first presentation. First of all, thank you, Mani. It was a delightful insight which you have shared with us. Your hardships and the short truths which you have given would, I think it should help everyone who's been part of this meeting. And also, yeah, I think over to Dr. Kaarthesan and Dr. Ananda Kannan for your comments.
Anand,
Dr. Anand sir, I think you're in mute. Dr. Anand sir, you're in mute.
I have nothing much to say, but hats off to Manikandan. After the MCH, you had the resolve to go through all this.
No, so that's why I'm telling you, like I didn't do my training here. So I came in, I did my FRCS now, And I am trying to go into the CSER route to get into the specialization, which I have not done yet, but I am trying, But the actual true fact is, if you have...
What I mean to say is, by finishing your MCH, all your steam is gone.
Yeah, very true. Very true.
After that, there is very less motivation to go further. I think should be started from very young age. It becomes much easier for them to go.
Yeah, very true. But the actual fact is, if you have very good contacts in UK and a very good relationship with any of the senior people in UK, getting into the UK and getting work things done is much, much easier. That's the actual fact.
I'd like to congratulate Mani actually.
Thanks, sir.
Because like lots of them, you want to help people.
Yeah.
The young surgeons to come there in a more easier route than rather than the hardship which you have undergone. I really appreciate your fantastic hand.
Thank you, sir.
Thank you.
Thank you, sir.
More comments,
guys, for all the PGs and other people, now Manikandan, you have a contact there. Slowly you start working from now on.
No, I think all youngsters should have a mentor.
Yeah, of course, yes.
That is a very, very important thing. I think some of the PGs can select Mani as a mentor, and it will really...
I'm very, very happy to help. Very, very happy to help. Yeah.
Any more questions from postgraduates? Dr. Dharmarajan, sir, your comments? Or is there any questions? If there is no questions, I'll ask some questions.
I think Dr. Dharmarajan sir has texted actually.
Texted. Mani, you have clearly told that post MCH, you have taken this route. So someone who's, for example, we'll give two scenarios. Post MBBS, he feels that maybe a son of a surgeon or son of a doctor who wants to enter UK for training alone. What you said was to go through the routine training route. That is
training
the
process.
easiest.
So instead of wasting time, so from the internship time, they can start preparing for the PLAB exams. Again, I'm telling you, PLAB exams are much, much easier than any of our NEET exams. So it is a majority of these exams are all clinical scenarios. So it basically motivates you to prepare for these exams when you start preparing for the exams. So it's all scenario based exams, and there are enough teaching areas or coaching centers which can provide this service. So they should start preparing for the exams, I would say, from the final year of the exams, and by internship, if they finish PLAB 1, for PLAB 2, they can come into the UK. So for students who come in for exams like this for a specific period of time, so they can come in, finish their exams, and then apply for it. And getting any kind of training post, again, so if you apply, you will get a post. You won't end up not having a post unless you have very strong problems in your CV or in your application or something.
See, that is very important, because not everyone is blessed enough to have people to fund you. So, so taking training as well as getting good pay is actually very important for someone's career, especially in the beginning of the career. So that's a fantastic thing which you're telling. And
especially the post MS graduates, because of all these things, who wants to get MCH, it is so difficult in India, and so coming into UK is one of the, I would say, it's one of the best ideas. You come in, you train yourself in a very core specialty, like you do a robotic training or you do a minimally invasive bariatric training. You do for 2 years. I am promising you will get a very good training. I can tell you, it's not just on the paper. You will get a training, and somehow or other, they will make you to write 2 papers, publish 2 or 3 papers, and then you go back with the tag. This will be 100 times more weighted than your MCH degree or a DM degree back home.
Yeah, that's fantastic. And Also for someone who's, as you said, someone who's trying to get into some specialty, doing a specialty course in UK, which is going to cost you much lesser, and then coming back here and getting recognized much better than your colleagues who have gone through the hardships in one of the premier institute, is that's a shortcut.
Yeah.
For
the interesting fact is, any FY1 doctor, which is the internship doctor, which I'm telling, by FY2, all FY2 doctors, they buy their own house here. They buy their own house here. Because here the trend is, by 18 years or 19 years, the people leave their family and come out. And then they start working, and then once they enter the FY1, as I told you, which is an internship, you will be paid something like 3,000 pounds a month, and everyone buys a home under loan, and they live in their own house. So that kind of independence you get. And even if you come here with the mindset of saving money and send back home, it is again a good option. People all think that.
And I think someone has asked a question. Good evening, sir. Thank you for the talk. Are currently MTI open for surgeons right now? Is MTI and the ITSP same?
Okay.
When we came as MTI, can we later shift through trainee post or internship to return is compulsory?
Yeah. So MTI and it's not ITSP, it's ISTP, I think, if I'm not wrong.
ISTP,
so MTI and ISTP both are
and
same.
I want to add on one thing. I think we are all part of the Indian Association of Gastro and Endoscopic Surgeons, and if I'm right, the FIAGS, the fellowship which is provided by the Indian Association of Gastrointestinal Endoscopic Surgeons, is recognized by the ITSP. And that is one more added point to your CV to just as you were telling.
I think this course is, whatever course you mentioned, it's recognized by Royal College actually.
It is recognized. It is recognized. In fact, we conducted Dr. Kaarthesan, Dr. Ananda, Kannan, and everyone, Dr. Govindraj sir and Dr. Zamir Basha was the head of it, and we conducted FAGS recently along with the Royal College attachment.
Yeah. And so basically, so both so MTI and ISTP are same actually. And if you want to get into the trainee post, you can do, but as I mentioned, you should have cleared a PLAB exam or an MRCS. If you have cleared a PLAB or an MRCS exam during so what people tend to do is, like they come in through the MTI program in the 2-year time. Using the UK experience, they write their Royal College exam, because when you are working in the UK, it makes life much more easier to clear these exams, because you just practice there and you write the answer whichever you are practicing. So they clear the exams and then they go into training program or whatever. So if you don't get a PLAB or a Royal College exam cleared, then you need to get out at 24 months. That's it. That's a rule.
So you have to finish your PLAB or whatever within that 24 months.
Yeah,
so it is like
MTI. It is a fixed visa and a fixed registration. Beyond that, you cannot stay there.
And you get paid, if I'm right, 5,000.
So you will be paid a minimum of say in an MTI, I think you will be paid somewhere around 60,000 pounds a year. So which comes to around something like, say again, as like
3,000 to 7. Yeah. And one other question. Good evening, sir. I'm second year postgraduate MS preparing for MCH in urology here. For training for urology in UK, I understand I should complete MRCS after that, sir. I think it is right now. You have to complete.
So he has to do MRCS. Of course, he needs to do an MRCS. Say either MRCS or he has to do a PLAB. So if he does an MRCS, so he can straight away enter into ST3 urology training.
Okay.
And then 5 years of ST3 urology training, he gets CCT in urology. And again, he has to do his FRCS exam.
FRCS there to continue.
FRCS is mandatory. Without FRCS, he cannot get his.
So someone out of the blue, if someone is completing the CCT, the complete training in a specialty, and doesn't do an FRCS, can he come back here?
No.
The intention is he can't get out of it.
No, for the CCT is something again like an application which you need to put. For the CCT, you need to submit the FRCS exams results. So FRCS exam result and
so
whatever
compulsory exit exam.
Yeah. Without FRCS, you cannot get CCT. And once the CCT means it is completion of training, and you enter into the specialist register. And specialist register entry is mandatory for you to become a consultant in UK.
Okay. And one other question from Dr. Harish. He's from Coimbatore. Finished his Gene surgery.
General surgeon. Oh, this guy. So Harish,
Okay.
Harish, I know him. So he's from Amrita, I think, if I'm not wrong. And I think general surgery in.
I never knew that such a short form for general surgery. We thought it's only GEN. It's GENE is written, so that confused me. If we enter, is it always ST3 or post MCH if we get a higher post?
No, nothing. So as I mentioned you, no one recognizes your MS or MCH here. So even if you finish MCH here, and if you want to enter the training pathway, you have to go back to ST3. That's the reason why I didn't take ST3, and I'm doing my senior clinical fellowship and trying the other most difficult pathway of CSER route to get the CCT. I think someone has put up a hand.
Dr. Prithvi has put up a hand. I'll just, Dr. Prithvi, I think you can unmute yourself. Yeah.
Yes, sir. Can you hear me?
Yes.
Yes, sir. Good evening, sir. I'm Dr. Prithvi. I'm your junior from PSG. Sir, first of all, fantastic presentation, sir. Like a structured presentation, like it was very hard for me to come by it, even in YouTube and all that. So happy to attend your presentation, sir. Sir, my doubt is actually something you have briefly touched upon, but I'd like even more confirmation. Sir, my current situation. Okay, basically, my plan is to enter the ST3 pathway, sir. I'm giving my MRCS exam, and then my plan is to enter the ST3 pathway and eventually get my CCT and become a consultant. That's my long-term plan, sir. But right now, the doubt I'm having is doing a PG in a private medical institution. I did not get much surgical training, sir. Like my theory knowledge is good, but my hands are not that great. And the two schools of thought I keep hearing is, one is before you enter into the UK, you work in a high volume center for at least a year or two, get good hands before you go. That is one school of thought. The other one is, no matter what we learn here in the UK, they are going to train you all the way from scratch. So instead of wasting your time here, enter into the pathway as soon as possible and then get into the training is the other school of thought. So
so I would advise you to take the second pathway. You know, don't waste time. Yeah, and as a surgeon, we would never be happy with whatever training we get. Okay, even now I cry that I'm not doing anything, and everyone does that. You know, so what I would advise you is don't waste time. So ST3 is it's the very beginning of a specialty training. So and they don't expect you to do wonders. So if you as an ST3, I would think that, so if you can put in a laparoscopic port and if you can do a basic laparotomy, it's more than enough. That is the basic requirement which they might expect. Although I'm not sure on this, I should not tell false things here, but this is what is expected from an ST3 person here when I work. So when I work here, and if some ST3 person comes here, the maximum thing which we will ask them to do is close the laparotomy wound or try to put in a port, and we will supervise. So don't waste time. Don't work in high volume center. If your interest is coming in, I am telling you, so even if you start from now, it takes 1.5 to 2 years. So in that time, you can use it, but don't waste time working there and then start your application process, which will take another 1.5 years. The other option, what you can do is, once you've done your MRCS, you can come in as a junior fellow or a senior fellow, work in some unit here, and then you can apply and get the ST3 post also. That's also an option.
Okay. And so even in that pathway that you're saying, that after finishing my MRCS, even then they are not expecting much competency from my end. Is that what you're saying, sir? Like, is it okay?
So basically what they expect is they need to know you should have a basic surgical skill that is called as the core surgical training, CT1 and CT2. So core surgical training is you should know how to handle these instruments, how to handle sutures, basic suturing techniques, putting lines, putting a chest tube, something like that. That's all. I think that's more than enough.
Okay, sir. Thank you so much.
And
sir.
on the other hand, how much ever you are trained, you are not going to have any extra points on that. I'm telling you, no one is going to recognize you if you tell that I have done so much back home, but you have done this alone. No one is going to recognize you. So don't waste time.
So maintaining a logbook right now also doesn't matter much.
No, it is extremely important. Please maintain a logbook. Okay. So from your training, from your scratch, from day one of your training, please do it. Although we were all lacking in it, I personally lacked in it, but somehow we worked in an institution where it's all computerized. So I gathered my information, but still the main advice which I failed to add in this. So everyone should maintain a logbook from day one. Whatever you do, whatever procedure you do, whatever, and then try to get some feedbacks also, you know. So once you present something, get some feedback from your mentors or a moderator or a unit chief. Once you finish your unit and go, get a written feedback from them telling how you worked and things like that. This all will add when you come into UK.
Thank you, Prithvi. And one other, the questions will be flowing to Mani, I guess. So what I request from everyone is please make note of Mani's WhatsApp number and emails, and push in all your questions there. He's happy to answer everyone.
I am happy to answer. Yeah, no problem at all. Yes.
And one last question, Mani.
Yes.
Ponnagiri Dilipan, he's currently doing his MCH cardiothoracic surgery. What is the route and chances of training in UK and to come back to India? He wants to come back to India. Okay. What he's asking is, should he do an MRCS or an MTA?
Yeah. So cardiothoracic surgery, again, it's one of the top training programs you have in UK. I think the big centers like Papworth and Hayfield are here, and which I think many Indian surgeons are there actually. So the best thing for you, I would suggest, is MTI, because you going back and doing an MRCS now will be very, very difficult, because you have been doing cardiothoracic surgery, and MRCS is like you need to go back, study breast, thyroid, varicose veins. You need to study ortho, which is very, very difficult. So I think for you, the best thing is MTI, and I'm telling you 100% you will get a spot in one of the, because there are only very few high-end cardiothoracic surgery units which provides MTI service. So you will be placed in one of these units and you can get trained and come back. I think you should go through MTI.
So I think that's answered, and please, if at all you're not able to reach out to Manikandan, you can reach me to reach his contacts. And thank you, everyone. I request Dr. Sowmya, who was our secretary. Sowmya is a breast surgeon, and she's from SRM Medical College, to deliver the vote of thanks. Thank you, Mani.
Thanks.
Thank you, Dr. Rajavel. Now, just like Dr. Anand said, I wish we had known you or met you like 10 to 12 years ago, sir. So, but your talk was really very helpful and honest. That's the next thing I would like to say. Really, thank you so much for making yourself available for so many people and younger surgeons. Now, I would like to thank Dr. Anand, my senior and friend, for being there for the presentation, and also all his inputs. And Kaarthesan sir, thank you so much. He was my again teacher and at SRM. And then a small mention of, we are really happy about the attendance here. We did not, expect so much, but then I'm really happy that so many people are there because the talk was so good. And I would like to thank KG sir, Yeganathan sir, Dharma sir, Parsati sir, and Stalin, Prakasham sir, and also from Coimbatore, Tanjore, and all the doctors who had joined from there, Dr. Sharada, Dr. Praveen, Dr. Rajiv Raj, all these people, thank you so much for joining in. And cheers. Really nice. Thank you. Thanks a lot.
Thank you.
Unfortunately, it's a virtual cheers.
Yeah. And Rajavel, if any of these postgraduates wants any specific topic on, say, about an MRCS exam or PLAB exam, or want to take through the training route or whatever related to UK training, I am happy to take a session for them either through ASI or through Medical College or whatever. I'm happy. Yeah. And we have quite a few friends who are really doing this kind of work, helping students, and so we can do that. Yeah.
I think Dr. Sowmya and Dr. Karthik, if he is part of it, Dr. Kaarthesan and Dr. Ananda Kannan, I think with all your words, Mani will be more busy than searching the liver.
So
to be there. And even for lady surgeons, whatever options are there, I would like you to, help.
Yeah, definitely. That will be a very good topic, actually. Yeah, just for lady surgeons.
And he's very happy to share.
Yeah.
Once you become a surgeon, you're no more a lady.
No. But then that's what I thought when I just passed out of MS. Then life teaches you, yes, you are a lady. So if we have options, we can earn equal to men with
Definitely.
I would really let them know.
Yeah, that's fine. So if you are working in SRM, so if you want any sessions to be done, or especially if you want to organize something for maybe lady surgeons, I'm very, very happy. And I have few other speakers. If you want specifically, say, if you want to give talk on breast surgery or oncoplastic surgery or whatever, we can make arrangements actually.
MBBS who are just finishing and trying to, clear NEET. So they'll also be very happy to.
Very true. Very true.
But the news of NEET is tougher than planned just broke my heart.
No, it's very, very true. It is NEET exam. So the reason why many students come to UK is because of this NEET. It is so difficult, and then the reservations attached to it is so difficult, so difficult. Yeah. See, when you enter UK, at least you will have something. Yeah.
Dharma sir wants to talk something.
Yeah, I'm Raj.
Yes, sir. Yes.
I'm just listening to you all.
Thank you, sir.
Thank you, MK.
Thank you.
Nice meeting you.
Manikandan Kathirvel.
Thank you, sir. Thank you, sir.
Thank you. It's very nice talking to you, MK.
Thank you,
Thank you very much for your valuable information.
Thank
and
you,
your help also.
So
the reason
there is
why
no
they
other.
are made, the reason why they are made NEET so difficult is India, we do a lot of work here compared to Western countries.
Yeah.
We are performing a lot of academic and achievements in all fields. But still, our Indian degree is not recognized in anywhere.
Very true, sir. Yeah.
If you compare the Indian doctors who trained here, they do better in UK and US than the fellows there in Europe. Knowledge-wise, skill-wise, confidence-wise. But still, our degree is not recognized everywhere. So that is why our government wants to make the standard of our exams to be higher than the West as well as the Asian thing. So that is the only reason they made this NEET exam a compulsory, and they are making it more difficult to bring the best ones out. So in another 5 years or 10 years, you can see our Indian degree will be recognized throughout the world.
So as you told, sir. Yes, sir.
Yeah, definitely.
Well said, sir. Well said. Dharma, sir.
No, as you told, sir, basically, the basic fact
5 to 10 years, in next 10 years, you see, people will be rushing to India to get learned
Very
come
true.
here
Very
for
true.
training.
Very true.
It's
So
going to repeat.
as you told very clearly, so most say in the UK, if they stop the surgeons or doctors coming from UK from India into UK, the entire system will collapse. So in my department where we have 50 doctors, 22 are from India actually. 22 doctors are from India. In that, I am proud to say that 7 are Tamil people actually. Seven surgeons are from Tamil Nadu actually. So it is like, so I don't feel anything different from how I work in back home. It's like India. All people are Indian surgeons, and this one. So they are always outsmart. They always outsmart any other European Union people or whoever. And the sad part is the degrees, the MS degrees from Pakistan is recognized, MS degree from Bangladesh is recognized, but the MS degree from India is not recognized. That's a fact. Yeah, so things are like that. So if you had an MS degree from Pakistan, you get GMC registration straight. You don't need a PLAB or MRCS. But I was told in the other.
Influence is not enough.
No, I was told in the other way. Like why intentionally this was kept by the Indian Medical Council is they don't want Indians to move out of the country. They don't like people moving out of the country. So intentionally, the Indian Medical Council or whatever doesn't want their degree equally fitted with the Western. That's what they told. I don't know, but this is the fact.
One more thing is.
Yes, sir.
In India, the university system is not national level. It is of the state level, district level, and autonomous. So many things are here. Whereas in other countries, it's only a national level. A single university controls everything. So it becomes easy for them to standardize and regularize everything. But in India, for the population and the benefit of the people who are coming from baseline, So we have this system for easy approach to the university, like.
True.
So that is the reason our degree is not standardized and they are not accepting it. That is the reason now the central government has taken up everything. They are making it into a national board. Right from our NEET, examinations, selections, everything is going to be under one board, like national board. As it becomes a national board for a couple of years, automatically it becomes equal to Westerners.
Very true. Very true. Very true.
Yeah. By 2025, you can see our Indian degrees will be more valid than anything else.
Hopefully, sir. Yes, sir.
Definitely.
Thank you, sir. Thank you, sir. Thank you, sir. If there is no further questions, I think thank you, Mani. Thank you, Anand, sir. Thank you, Dharma, sir. Thank you, Kaarthesan, sir. Thank you, Soumya, ma'am. Thank you, Rajiv, sir.
Wonderful topic.
Thank you. Thank you, sir. Thank you, sir.
you.
Unfortunately, we cannot treat ourselves with the routine fellowships. Hope we'll all join together and have money here once he is here for some time. Money, you will enjoy the Trichy's hospitality.
100% I will come. Na Salem da, sir. I am from Salem.
Thank you, Mani. Thank you, sir. Thank you, everyone. Thank you.
Thank you very much. Good night.
Bye. Good night.